with chronic kidney disease. As long as a patient has microalbuminuria, that will be considered evidence of kidney disease. And that thing you look for in chronic kidney disease is the GFR. GFR has to be less than 60.
Okay, let's.
Less than 60, yes.
You said that.
Do you mind if you speak into the mic, please? Or just vocalize? And I'm in the front too.
Okay, can you hear me?
I appreciate that, thank you.
In the situation, I'm in to use the board.
Okay.
Okay.
Can you say you
Okay, so case 3.
Oh, leave it. No, he said he was gonna use the board.
No, I'm just gonna move it up though.
Ooh, be careful, Dr. Bo. It's broken.
It's broken, it's not you. There you go.
Okay, so the chief complaint here will be I feel tired, nauseated, and constipated. History of renal illness. Jill is a 43-year-old woman who presents to the outpatient dialysis center for routine hemodialysis treatment. She has end-stage kidney disease, secondary to hypertension, and has been on hemodialysis for 4 years. She has failed AV fistula and graft and is currently dialyzed via central venous catheter. She has an upcoming appointment with the vascular surgeon to reevaluate her hemodialysis access. She also frequently leaves hemodialysis 30 to 60 minutes early against medical advice. And this is the past medical history. End-stage renal disease. When you say a patient has end-stage renal disease, you know? When do we say a patient has end-stage renal disease? Less than 15, so that will be stage 5.
Stage 5 is less than 15?
Yes. Based on the kidney disease improvement global outcomes, you'll be less than 15. That's when they need dialysis. That's basically where you say kidney has failed. So the patient has end-stage renal disease secondary to hypertension. The other problem is hypertension. The patient has anemia. Secondary hyperparathyroidism, that's with PTH, GERD, and these are the meds. So again, you should focus on the meds. See, you should be able to link a med to a problem. So in terms of reconciliation, you want to associate the medication to a problem. So by doing that, you may come across some medications that the patient has no indication for. So that will indicate that you need to contact the PCP for that patient. So basically, there should be an indication for every medication the patient is taking. So furosemide, metoprolol, lisinopril, calcium acetate, decals, POTID with meals. Now, if you look at the patient's lab, then you should be able to tell me why the patient is on calcium acetate. Cinecalcet, again, if you look at the lab, you should be able to tell me why the patient is on cinecalcet. Nephrovite, most patients with chronic kidney disease, they are malnourished, so they tend to be on the multivitamins. Omeprazole, we see this patient has GERD, so that's most likely why the patient is on omeprazole. Zolpidem, ferrous sulfate, docosate, calcium carbonate, epoetin alpha, iron sucrose. Now the patient has anemia of chronic kidney disease. That's why they're on equating alpha. And we find that one of the reasons the patient may be getting iron concurrently is that when you expose the patient to erythropoietin stimulating agent, that's going to increase utilization of iron. So if the patient does not have iron, adequate iron, they're not going to respond to the equating. So that's one of the most common reasons patients do not respond to erythropoietin stimulating agent, because they lack iron. So before a patient is given erythropoietin stimulating agent, they have to do baseline studies, which will include iron studies. If you look at the patient's medication profile, the patient is on calcium acetate, most likely to bind phosphate. The patient is also on calcium carbonate for heartburn. So that's a lot of calcium this patient will be exposed to. Even though the patient will be taking the calcium acetate to bind phosphate, some of that calcium is also absorbed. And now the patient is also taking calcium carbonate that will also be absorbed. So that's it's going to increase the risk of hypercalcemia in this patient. We also need to look at the indication for the calcium carbonate. It's a PRN heartburn. So the patient has GERD and the patient is omeprazole. So we need to evaluate the dose of omeprazole. But if the patient is getting effective omeprazole dose, there should be no need for PRN calcium carbonate. Okay. So these are the labs. We can see that the hemoglobin is low. The BUN is elevated, serum creatinine is elevated, hematocrit is low. Now, albumin is low. Each time albumin is low, we also want to do, even though this calcium is okay, we still need to do correct the calcium based on albumin. The reason we're doing that is because when a patient has hyperphosphatemia, the phosphate level here, the upper limit of normal is 4.5. So in this case, it's 6.7, so it's elevated. So that's the reason why this patient is on calcium acetate, because of the elevated phosphate. Now, the calcium acetate will serve to bind the phosphate in the diet, and it also serves as calcium supplement. It will bind some phosphate in the GI. At the same time, some of the calcium will also be absorbed. So a lot of these patients may also come in with hypocalcemia. Okay. So, the reason why we need to do the corrected calcium is that calcium is bound to albumin, and if albumin is low, calcium level also tends to be low. So typically, we want to multiply the calcium level by the phosphate level. We want to multiply the calcium level by the phosphate level to get calcium phosphate product. We want to get a calcium phosphate product, so we multiply the level of the calcium by the level of the phosphate. We want it to be less than 55. We want the level to be less than 55. If the level is greater than 55, the patient risk, if you expose the calcium, they risk calcification of their organs. So we want to make sure the level is less than 55. And we do that by looking for the calcium phosphate product. So we multiply the calcium level by the phosphate level. Okay. Okay, so like we did previously, once we have a case like this, we need to collect data, assess the information, develop a plan, implement the plan, and follow up to see how the patient is doing. So in this case, we already have information from the history and physical. We have a past medical history. So we just need to get all this information from the patient's record. And once we do that, we need to assess the information. We need to determine the patient's glomerular filtration rate or creatinine clearance. Basically, we say this patient has chronic kidney disease, we expect the GFR to be low. We expect the GFR to be low. That's one of the criteria you use to determine chronic kidney disease, the GFR. Another factor would be albumin in the urine. So presence of albumin in the urine. We also check potassium because the kidney will not be able to excrete potassium, so they tend to retain potassium. We also need to check the hemoglobin because these patients eventually will develop anemia. They develop anemia because of lack of erythropoietin. The kidney produces erythropoietin, and in chronic kidney disease, the kidney loses its ability to produce erythropoietin. So this patient do not have sufficient erythropoiesis. So we need to check. So that's one of the reasons why this patient will have anemia, typically anemia of chronic kidney disease. So we need to check the hemoglobin. So if this patient is going to need erythropoiesis stimulating agent, you need to do baseline studies, which will include iron studies. So we're going to do transferrin saturation and ferritin. We're also going to do what is called the TSAT, transferrin saturation, TSAT. The TSAT level is important if you want to initiate erythropoiesis stimulating agent. You want this patient to have immediate response. Now, the TSAT level the number has to be greater than 20%. It has to be greater than 20%. If it's less than 20% and you want to give erythropoietin stimulating agent, you do not give oral iron. You give injectable form of iron to boost up the iron supply. So the determination whether to give IV iron or to give pure iron will dependent on the TSAT level. So you want the baseline, the TSAT level should be greater than 20%. And you can determine the TSAT level if you're given the patient's lab values that would include the iron. So basically, the iron studies, that's where you're going to get your information from. But basically, the TSAT will be equal to the measured iron divided by the total iron binding capacity. The measured iron divided by the TIBC, which will also be given. Then you multiply that by 100, it should give you the TSAT.
Are we doing this calculation from the exam?
What?
Are we doing this on the exam?
But if you see it, then you have to do it. Okay. So we also need to look at medication adherence. We need to check to make sure these patients are taking their medications. And that's where the pharmacists come in terms of reinforcement. We'll also check for potential drug-drug interactions. Now, since the patient may be on medication that require dosage adjustment because of the renal insufficiency, then we need to look at those medications that require renal adjustment. So we need to develop a plan, including any recommendations, monitoring parameters. For example, if we give a patient erythropoietin stimulating agent, how do we know this patient is responding? Can anyone tell me if you give Epogen, how can you tell that the patient is responding to the Epogen dose? Okay, it's gonna take some time for you to get any response. The fastest indicator of response is gonna be reticulocytes, which takes place in about 1 week to 10 days. Yeah, for the reticulocytes. So basically, the patient is responding, reticulocytes should be going up. And you see that between a week and 10 days. If you look at the hemoglobin, it takes about 4 to 6 weeks, so that's a long time. So the earliest you can determine if the patient is responding is look at the reticulocyte count. Okay. So we also need to look at educating the patient in terms of their medication. We talked about phosphate, yes. TIBC, total ion binding capacity. Total ion binding capacity. Okay, so we talked about phosphate. In the case I presented, the phosphate level was 6.7. And we said the patient was getting, which medication did we say the patient was taking to lower the phosphate? On the patient's profile. What? Calcium acetate, thank you, ma'am. Calcium acetate.
To lower the phosphate.
We said calcium acetate can lower the phosphate and it can also serve as calcium supplement. So it can be absorbed. So it can bind the phosphate locally in the GI and it can also serve as calcium supplement because this patient can also be hypocalcemic. So calcium acetate, calcium carbonate, they can serve two roles, as calcium supplement and as phosphate binders. So in terms of educating patients, they need to know when to take the phosphate binder. All phosphate binders, they don't have to be calcium. All phosphate binders have to be taken with meals. All phosphate binders have to be taken with meals. Not after meals, not before meals, with meals. So they can bind phosphate in the diet. That's how they work. Okay. So we have a plan, we have to implement the plan and follow up to see if the patient is responding. We use the erythropoietin stimulating agent as an example in terms of monitoring the response. Okay, so basically that was a case of chronic kidney disease. So let's talk about it, the process itself. Unlike acute kidney injury, chronic kidney disease can occur over months to years. It's very gradual, so the patient may not be aware of it. It's very gradual. One of the things we look for will be the GFR. Usually it has to be less than 60. And if it's less than 60 the first time, you want to do it sequentially. Usually it has to be within less than 60 for 3 consecutive months. For 3 consecutive months. Also, in addition to the GFR being affected, the endocrine renal activity of the kidney is also affected. We talked about erythropoietin. The production of erythropoietin is reduced, or it may be deficient. So that's the endocrine activity of the kidney. Also, the kidney has an enzymatic activity where it can convert vitamin D to its active form. Now, the active form of vitamin D is 1-alpha 25 dihydroxy vitamin D3. That's the active form. 1-alpha 25 dihydroxy vitamin D3. Basically, this is the active form of vitamin D. The 25 position is hydroxylated in the liver. 25 position is hydroxylated in the liver. Then when it gets to the kidney, it is alpha hydroxylated at the 1 position. So for it to be active, it has to be hydroxylated at the 1-alpha position. So we find that because of kidney failure, a lot of patients cannot hydroxylate the vitamin D at the 1-alpha position. And one of the aims of the vitamin D is to help with the absorption of calcium. So that's one of the primary reasons this patient may have hypocalcemia. So when you give them vitamin D supplement, you have to give them the active form of vitamin D. So all patients who have chronic kidney disease will have progressive azotemia, basically increase in the BUN, hyperphosphatemia, increase in phosphate, hypocalcemia, low calcium levels, hyperkalemia, high potassium, and because they lose bicarbonate, they end up having metabolic acidosis because of hydrogen ions that are being retained. We just talked about the effect of erythropoietin, so this patient will also have anemia of chronic disease. So this is complications you find in chronic kidney disease that will need management. One other condition I didn't have here will be edema. You may also have edema that will require management with diuretics. So based on the kidney disease improving global outcomes, these are the stages of the chronic kidney disease based on the GFR. Based on the GFR. So like we discussed a while ago, less than 15 will be G5, stage 5. That's where they have kidney failure. And this is where they actually will be on permanent dialysis or require renal transplant. Now this is a busy slide, but basically this, we talked about this yesterday, that every patient who has diabetes and they have proteinuria, I asked you about one class of drug this patient need to be on. What was the class of drug we talked about yesterday? ACE inhibitor. So they can be an ACE inhibitor or ARB. ACE inhibitor or ARB. So they have diabetes, hypertension, and albuminuria. They need to be on ACE inhibitors. So this is just a list of available ACE inhibitors. So basically, this slide tells you how the ACE inhibitors help these patients. So typically, when you have a normal blood flow and you have the normal glomerular capillary pressure, there are no issues. But once you start having reduced nephron mass or your renal function is declining, then compensation kicks in. So here, this is where you need prostaglandins to increase with the perfusion. So prostaglandin will cause the efferent artery to dilate. So that will enhance blood flow. The prostaglandin will enhance blood flow. Meanwhile, angiotensin 2 causes constriction at the efferent. Angiotensin 2 causes constriction at the efferent artery. And that vasoconstriction will now increase the glomerular capillary pressure. And if that pressure is sustained, then that will cause damage. If that pressure is sustained, it will cause damage. So this is where the ACE inhibitors come in to inhibit the angiotensin 2 production. This is where the ACE inhibitors come in. So when we say the ACE inhibitors are renal protective, this is basically where they come in by blocking angiotensin 2 here. So that will reduce the intraglomerular pressure. We also talked about the use of metformin in kidney disease in patients who have diabetes. So it will be first line drug to use. As long as the patient's GFR is 30 or greater. If the GFR is less than 30, metformin will be contraindicated. If the GFR is less than 30, metformin will be contraindicated. Even where the GFR is less than 45, then you have to use caution. And that's where you need to decrease the dose of the metformin. If the GFR is less than 45, decrease the dose of metformin. If the GFR is less than 30, metformin is contraindicated. So basically, this slide just tells you some of the algorithm you may come into in terms of the use of metformin. If the GFR is less than 45, then you need to reduce the dose to about 1 gram per day. If the GFR is greater than 45, you may give the normal dose. But less than 45, you can decrease the dose to half the normal dose, which is about 1 gram per day. Now, metformin is, again, remains the first line in terms of lowering the hemoglobin A1C. Can also be given orally. And it can either have neutral effect on weight or it can cause weight reduction. It can have a neutral weight effect or it can cause weight reduction. This is one of the reasons why obese diabetic patients get metformin. It doesn't cause weight gain. They can maintain the weight or they can lose weight. And it also has some cardiovascular benefits. So usually it's gonna be the first line medication unless there is a contraindication. Then we can look at other agents that you can use. Another class of agents you can use would be the sodium glucose co-transport inhibitors, type 2 inhibitors. Again, using this class of medication will also be based on GFR, just like metformin. The SGLT2 inhibitors will also be based on GFR. Now, if a patient is on metformin and they're not getting adequate response, again, this is not a diabetes class, this is just supplemental information. So if a patient is on metformin and they're not getting adequate response, you can add a second line agent. In this case, you can add the SGLT inhibitors. Now, if they still not at target or they have bad reactions, the other options will include the glucagon-like peptides agonists, DPP4. So these will be the alternatives, but the GLP-1 agonist will be the preferred agents if they cannot tolerate metformin or they cannot use SGLT2 inhibitors. So the third choice would be glucagon-like peptide 1 receptor inhibitors. Now the advantage of these agents here is that the use will not depend on the GFR. So if the patient has contraindication for metformin, then they can use these agents, because their use is not based on GFR. And the two common drugs here will be dulaglutide and semaglutide. These are the second generation agents. So these are options patients can use if they have issues with metformin or the sodium glucose transport 2 inhibitors. Okay. So in terms of management of the chronic kidney disease, the management is going to be similar to what we had in acute kidney injury. We have to look at the salt and water balance. A lot of these patients, because of decreased renal function, they have inadequate or lack of ability to regulate fluid and electrolytes, so they can be volume overloaded. And the volume overload can induce hypertension, it can cause edema, it can cause congestive heart failure. If the patients already have these conditions, then the condition will be exacerbated. So we need to manage the volume in these patients. Now, in terms of volume management, we talked about the loop diuretics. The loop diuretics will be the agent of choice to manage volume overload. We can add thiazide type diuretics if the patients have ceiling effect from the loop diuretics. Now, we said yesterday if creatinine clearance is less than 20 to 30, you don't use a thiazide type diuretic except metolazone. Metolazone is a thiazide type diuretic. That's the exception if the creatinine clearance is between 20 and 30. Other than that, you do not use thiazide diuretics if the creatinine clearance is less than 20 to 30. So in these patients with chronic kidney disease, their volume overloaded, we need to think about low diuretic. The standard low diuretic is going to be furosemide. Now, talking about furosemide, since these patients have a chronic condition, they have chronic kidney disease, so it's a chronic condition, and they will be volume overloaded for a while, that means they may be on furosemide for a long time. What will be a consequence of being on long-term furosemide?
Said toxicity.
Bone loss? Can you explain what you mean by bone loss?
Bone density, I don't know, just, I read that, diuretics.
Okay. So, one, furosemide is going to deplete potassium, it's going to cause potassium loss. Two, chronic use will result in, like Pierre said here, they're going to cause a loss of mineral bone density. Because it cause what? Why do they cause the loss of the mineral bone density? The low diuretics. And because of this effect, they also may be used for another condition. Okay, they cause calcium loss. So they cause calciuria. Calcium in the urine. They cause calciuria. So you lose calcium in the urine. So it makes the bone to be brittle. It can fracture easily. So that's one of the long-term consequences of furosemide. And because of this, some patients who have hypercalcemia that may be associated with malignancy, one of the therapies they get initially will be furosemide to get rid of the calcium in the urine. So you may see furosemide being used to treat hypercalcemia. This will be because it causes calcium loss in the urine. Okay. So patient may also need salt restriction. Hyperkalemia, we just discussed that. Now, let me go back to the slide from yesterday. Okay, so we discussed hyperkalemia yesterday. Remember we said calcium chloride, calcium gluconate is not used to reduce hyperkalemia. I did emphasize that. You use it when the patients have EKG changes that are associated with hyperkalemia. Now, some clinicians don't even wait for the EKG. Once the potassium level is elevated, they just give them this before they even see the EKG result. But when you see calcium gluconate, calcium chloride being used, you need to check for hyperkalemia. Now, most commonly you find the calcium gluconate being used rather than calcium chloride. Can you guess why?
What was the question?
Calcium gluconate is more commonly used compared to calcium chloride. The calcium gluconate is less irritating. Calcium gluconate is less irritating when you give it IV. So in terms of potassium reduction, we have sodium polystyrene sulfonate, which is a cation exchange resin, Now we will exchange sodium for potassium in the GI. So you need to be careful too in patients who are sodium restricted. You can give it orally, you can also give it rectally. One of my exams, long time ago, I put a route of administration IV and some students picked that up too. It's a suspension. So you don't give it IV. You give it orally, you give it rectally. And several years ago, it used to come mixed in sorbitol, and the sorbitol itself used to cause issues in the GI issues. So now the sorbitol has been removed. Okay. Pachyderma is also a cation exchange resin. Pachyderma, Valtesa is also a cation exchange resin. Insulin with glucose. We said insulin will cause a shift of the potassium into the cell. In order to avoid hypoglycemia, we give it with dextrose. So it can be dextrose D20, it can be D50, depending on what the pharmacy has. They can reconstitute the dextrose. We can also give beta-2 agonists. Example was albuterol, can be given as inhalation. And if the hyperkalemia is also life-threatening, you can place the patient on dialysis to remove the potassium. Okay, so this is how we manage the hyperkalemia. So in chronic kidney disease and acute kidney injuries, the management is going to be the same. Okay, so in terms of mineral and bone disease, we're talking about the effect of phosphorus, calcium, PTH. Now, high phosphate levels, hyperphosphatemia, and hypocalcemia can individually cause the release of PTH. If the patient has sustained hypocalcemia, that can trigger PTH release, which can cause disruption of the bone matrix, releasing calcium. So you can see calcium being released from the bone because of the effect of the PTH. The same thing happens if the patient has hyperphosphatemia. As the kidney gets declining in function, the ability to excrete phosphate decreases. So that hyperphosphatemia will also trigger the release of phosphate.
So, low salt retention and
Hypocalcemia, low calcium level, and high phosphate levels can trigger PTH release. And this is what results in the bone damage because you now have calcium being released from the bones. And patient will eventually have what is called osteodystrophy. Because of the bone effect, they have bone pain, fractures, muscle weakness, muscle pain, and they tend to shy away from using that muscle, so they eventually may develop atrophy. So this is a consequence of the mineral bone disease. You're going to see some of this. And it's triggered by phosphate, calcium, and PTH. So we talked about fluid restriction a while ago, where you have to do intake and output. So usually at the patient's bedside, you're going to have, the patient is an institution, you're going to have a flow sheet by the bedside, monitoring the intake and the output. You want to make sure the intake basically you're more worried about the output, to make sure they're not returning volume. And we talked about the management of acidosis. It's going to be the same. Sodium bicarb, show solution. We talked about sodium citrate, citric acid, potassium citrate, citric acid yesterday, so it's going to be the same thing. And we talked about ineffectiveness of the sodium citrate, citric acid. The patient have liver dysfunction because the citrate depends on the liver to be converted to bicarb. So if the patient has liver disease, they're not going to benefit from citrate, citric acid. Instead, you give them sodium bicarbonate. Hyperkalemia, we just went through that a few minutes ago. And we talked about calcium supplement. If the patient has hypocalcemia, but their phosphate level is okay, and you want to supplement just the calcium, before you make that decision, you also need to check the patient's albumin. You need to check the patient's albumin. If the patient's albumin is normal, basically normal here will be lower limit of normal is 3.5. So if it's 3.5 and above, yeah, you can decide to give supplement. But if the albumin is less than 3.5, then you need to determine the correction factor for the calcium based on the albumin. So that's what you have in your handout. So the patients, for example, the patient's albumin level comes back as 3. So in order to correct, patient's albumin is 3, and the calcium, let's say the calcium is 8.4. So you're going to correct for that. So you're going to use albumin. In this case, we're going to use the literature albumin level of 4. We're going to say 4 minus the patient's observed albumin, which is 3. So it's going to be 4 minus 3. Multiply that by 0.8 plus the current calcium level, which is 8.4. So usually that's going to bump up this calcium level. It's going to bump up this calcium level. So you make this determination only if the albumin is less than 3.5 before you decide whether to give calcium supplement or not. Okay.
So where does the 0.8 come from? Oh, I see. The 0.8 in, what is that?
The amount of of calcium. That's the amount of calcium, albumin bound to albumin. 80%.
Oh, okay.
Okay, we also talked about vitamin D being crucial in the absorption of calcium from the GI. And this is the pathway for the vitamin D. We said the hydroxylation on the 25 position takes place in the liver. But 25 hydroxy vitamin D is still not active. For it to be active, it also has to be hydroxylated at the 1-alpha position. And the 1-alpha hydroxylation takes place in the kidney. So this is the pathway. So 25 hydroxy will now be hydroxylated at the 1-alpha position in the kidney. I will find that patients who have kidney disease are not able to do this. That's why you need to give them active form of vitamin D. Is that clear? Okay. So these are some vitamin D analogs. On this list here, the most commonly used there will be calcitriol. Calcitriol will be the most commonly used agent. Now, if you give a patient, if the patient is hypocalcemic, and you give them calcium supplement, at the same time give them vitamin D, there's a risk of having hypercalcemia in this patient. So that needs to be monitored. You give vitamin D to enhance calcium absorption, and you also give calcium supplement, or you give calcium as a phosphate binder. Remember, when you give calcium as a phosphate binder, that part of calcium is also absorbed. So anytime you expose the patients to vitamin D and calcium, there's a risk of hypercalcemia. Now, like I mentioned, calcitriol is the most commonly used vitamin D analog. However, pyracalcitol and doxycalciferol cause less degree of hypercalcemia. So if you worry about hypercalcemia, you may fall back on pyracalcitol and doxycalciferol because they tend to cause less hypercalcemia compared to calcitriol. Another use of, basically not a use, but another effect of this calcium, vitamin D analog, they can also inhibit PTH. The vitamin D can also inhibit PTH, especially the calcitriol. Not only will calcitriol increase calcium absorption, it can also inhibit PTH. PTH, parathyroid hormone. And right here we talked about the calcium phosphate product. It has to be less than 55. Okay, so these are some of vitamin analogs in terms of their formulation and dosage. So typically with the calcitriol, usually the starting dose will be 0.25 microgram. I can titrate up to 1 microgram. So the starting dose is usually going to be 0.25 microgram oral. If you look at the these agents here, you can also see that one of the things you monitor is the PTH because it can also affect the PTH level. In addition to increasing calcium absorption, it can also inhibit PTH level. So in terms of managing hyperphosphatemia, without the phosphate binding agents, aluminum is still available, but it's not recommended. Aluminum preparations basically were the first phosphate binders, but they're no longer recommended because of the adverse effect. They can accumulate in renal insufficiency, and they have some neurologic and bone toxicities. So because of the neurologic and bone toxicities, they're no longer recommended. They're still available for use, but they're not recommended. Now,
In what case would you still use it if it's not recommended?
that's what I was about to say. The only time you can use aluminum as a phosphate binder, remember we talked about the phosphate, the calcium phosphate product has to be less than what? If it's more than 55 and the patient's calcium is more than 55 and the patient's phosphate is still elevated, this is a situation where you can give aluminum to bind the phosphate until you get it down to about 6. So this is where you can use aluminum to bind the phosphate. You want to bring it down to about 6 before you resume calcium preparation. So basically we're using short term when the phosphate level is 7 or greater. You want to use the aluminum to bring the phosphate level down to about 6 before you start the calcium. So another thing about aluminum, besides the neurologic and bone toxicity, one of the more common effects, before we knew about neurologic effect and bone toxicity, one of the effects that we knew about was constipation. So you don't want to expose a patient who has a history of constipation to aluminum.
Can you go over one more time when we would, I know you said we would use the aluminum when the phosphate level was 7 or greater. But you said something before that about the calcium, when we do the,
If we say the calcium phosphate product exceeds 55, and you also look at the phosphate level. If the phosphate level is 7 or more, then you want to use aluminum to bring down the phosphate to around 6 before you give them calcium. Basically, what you're trying to prevent is calcification of the various organs.
thank you.
These are some of the calcium and phosphate binders. Calcium carbonate, calcium acetate. The most commonly used agent will be calcium carbonate or calcium acetate. Now the calcium acetate, example, the first medication, the first brand was the Foslo. It's a little bit, just a little more effective than carbonate, but much more expensive. So a lot of institutions restrict the use of calcium acetate. You need to justify why you want to use calcium acetate instead of calcium carbonate. A lot of the time the reason is that the patient is not responding and they will approve it. Also, a patient may be on Foslo and they decide to switch to a drug like Sevelema.
Would you call it
Renal, Sevelema. Renal. So a patient may be on Foslo or calcium acetate and you decide to switch them to Renal. The most common reason for doing that would be that the patient has developed hypercalcemia. You find that the patient has developed hypercalcemia. So, Renal is non-calcium phosphate binder. It does not contain calcium. Whereas phosphate contains calcium. So when you see a switch like that, usually it's going to be because the patient has developed some hypercalcemia. So you switch to a non-calcium phosphate binder. So if the patient is started on calcium carbonate and they're also on vitamin D, we say you need to watch out for what? Hypercalcemia. Hypercalcemia. So another class of phosphate binder would include the non-calcium, non-aluminum binders, which includes sevelamer, lanthanum carbonate. Now, with the hydrochloride salt was the first that came out before the Renal. Now, the disadvantage of the Renal, the hydrochloride preparation is that these patients may already have. Now, also remember that this preparation are indicated in chronic kidney disease patients. So they may also have metabolic acidosis. So when you expose them to Renal, the sevelamer hydrochloride, you increase exacerbation of the acidosis. You increase the exacerbation of the acidosis. So,
If you give them the
Renal because of the hydrochloride component, the hydrochloride salt. But if you give them the carbonate, that mitigates that acidosis you will induce. So you find that if you're thinking about metabolic acidosis and you want to use sevelamer, you use the sevelamer carbonate. You do not use the hydrochloride if the patient has acidosis. If they have acidosis, you use the sevelamer carbonate. Yes?
Can the Renal put them in acidosis if they don't already have it?
It will increase the risk of acidosis. And remember, this patient, if they have this medication indicated in chronic kidney disease, and that condition already predisposes them to acidosis.
Okay.
Because they're losing bicarbonate and just retaining hydrogen ions. So if you expose them to sevelamer hydrochloride, you even increase the risk of acidosis. So instead you use the carbonate. The carbonate has not been shown to induce acidosis. Now also, the lanthanum carbonate phosphorinol is also doesn't contain aluminum, doesn't contain calcium. It also binds phosphate in the GI. And the difference here is that the phosphorinol is chewable. They don't swallow it whole, the tablet. They have to chew it. They do not swallow the whole tablet. It's a chewable tablet. That's very important for the patients to know. A lot of these patients who have chronic kidney disease, they may also have dyslipidemia. They may also have dyslipidemia. Talking about the lipid levels, profile. So the sevelamer also can be used to lower the risk of heart attack in terms of dyslipidemia. Basically, we're talking about the LDL So it can reduce the LDL up to about 30%, just like other medications. So that would be another advantage to using cerebellum. But again, cerebellum is usually indicated in chronic kidney disease. So again, in metabolic acidosis, if you're thinking about using cerebellum, the carbonate is preferable because of the lower risk of acidosis. Remember, the lanthanum carbonate is chewable. Patients have to chew it. All the phosphate binders, they have to be taken with meals. All the phosphate binders have to be taken with meals. Not after meals, not before meals, with meals. This table just gives you a conversion factor, how you start the patient based on the phosphate levels. If you want to switch from patient from phosphate or calcium acetate, this gives you a table for switching. So we also have iron phosphate binders, basically iron-based phosphate binders. So we have calcium, we talked about aluminum, calcium, cerebellum, lanthanum, and now we also have iron-based phosphate binders. So the two products we have will be ferric citrate and the sucroferric oxyhydroxide. They can be used to bind phosphate just like you use the other agents. Now, these two ion products have a difference. The ferric citrate can bind the phosphate and it can also serve as ion supplement. The ferric citrate can bind the phosphate and it can also serve as ion supplement. So basically, part of the ferric citrate can be absorbed. Some of the ferric citrate can be absorbed, serving as a ferric ion supplement. Unlike the sucroferric oxyhydroxide, the sucroferric oxyhydroxide is not absorbable. Only the ferric citrate is absorbable. So that's the difference between the two ion preparations. So these are the two available ion-based phosphate binding agents.
So it only binds the sucroferric. It can't be a supplement, only a phosphate bond.
Only the ferric citrate can be used as ion supplement.
But,
Yeah.
but the sucro is only a bond.
Sucroferric is non-absorbable.
Got it.
Yeah. We also have an agent that can be used specifically for patients who have elevated PTH. They have secondary hyperparathyroidism. Patients who have secondary hyperparathyroidism, chronic kidney disease. Cinecalcet is specifically used for that indication. Cinecalcet does not bind phosphate. It's not a calcium supplement. It's indicated for patients who have secondary hyperparathyroidism, increase in PTH. Usually, it's commonly recommended in patients in stage 5 kidney disease. Usually recommended in stage 5 kidney disease, where the GFR is less than 15. That does not mean it cannot be used for other patients, but that's the primary indication. And the patient usually have to be on dialysis. Usually starting dose will be 30 milligram, and you can titrate up every 2 to 4 weeks. You usually double. Go from 30 to 60 to 90 to 120. Now, you don't want to go down, when you try to reduce the PTH level, you're not shooting to be abnormal target. Usually, if you can bring the PTH level to about 150 to 300, that will be adequate. Some patients may have a PTH level of over 600. So your goal is not to bring it down to less than 150. Your goal is to be between 150 and 300 when you use cinacalcet. Now, cinacalcet is contraindicated if the patient has hypocalcemia. Cinacalcet is contraindicated if the patient has hypocalcemia. Why? Because cinacalcet can also induce hypocalcemia. Basically, it's classified as calcium mimetic. It can mimic the effect of calcium. It can stimulate the receptor and inhibit the PTH, and that will cause decreased absorption of calcium. So if the patient is already hypocalcemic, that can exacerbate it. So if the patient is hypocalcemic, they don't use cinacalcet. So its primary indication will be secondary hyperparathyroidism. It's not used as calcium supplement. Don't confuse the classification or the name as a calcium supplement product. Of course, the brand name is for Sensipa, so make sure you know that. Now, if we need to use parenteral preparation, Pasabib is a product that can be used intravenously, but the disadvantage is that these patients need to be on this medication chronically, so it's preferable to give an oral agent, but the IV preparation is always there. And typically, if you give them Pasabib, you typically give them after dialysis. So usually this medication will be at a dialysis site for them to use. And you see that when you give this medication, the dose is usually TIW 3 times a week. That's because most patients get their dialysis 3 times a week. So they get it after dialysis. Now the last topic we need to talk about is the erythropoiesis stimulating agents. Again, patients have anemia from chronic disease, kidney failure. Typically, if you're going to give them a erythropoiesis stimulating agent, your target is the hemoglobin, so you need to look at the hemoglobin. We're not looking at the hematocrit, we're just looking at the hemoglobin. So it has to be less than 10 grams per deciliter. It has to be less than 10 grams per deciliter. And you don't want to bring your hemoglobin level to normal range, say 12 to 18. That's not the goal. The goal is to bring your hemoglobin up to about 11. Some references will tell you 11.5. The FDA says that the level must if you give erythropoiesis stimulating level, erythropoiesis stimulating agent, your hemoglobin must not exceed 12. The hemoglobin must not exceed 12. That's a black box warning because of the effect of these agents. So their target is 11. Some clinicians go to 11.5, but your target is 11.
So for the test it's 11. For your exam it's 11
What? You
or
will make,
11.5.
you will make that decision. The decision you have to make. Based on it, you have to make that
That's right.
decision. I'm not going to tell you what the answer is going to be. You made the decision. Okay. So, if you give erythropoietin stimulating agent, usually it's going to be, it can be 3 times a week, or the 3 weekly doses can be combined as 1 weekly dose. So the patient can get it 3 times a week or once a week. Now the 3 times a week, which was the standard regimen, was based on dialysis, because patients also get their dialysis 3 times a week. So they get these medications after each dialysis. But now studies have shown that if you combine the weekly doses as one single dose, it's just as effective as 3 weekly doses. But these medications will be given usually after dialysis. You also have divalproetin, RNF. In this case, it's going to be, because of the long duration of action, it's going to be just 1 weekly dose. And this can be given IV or sub-Q. Again, the target of hemoglobin is going to be still 11 grams per deciliter. You also have a erythropoietin receptor activator. It's not a stimulating agent, it's just a receptor activator. And Mircera is available, but again, it's not commonly used, but it's available. And this chart just gives you a conversion. If you want to go from equating to Mircera. So these are some of the baseline studies you do before you give erythropoietin stimulating agents. Iron level. In most institutions they have protocol. If you don't do these studies, pharmacy will not release the use of erythropoietin. So you have to do these baseline studies first. So iron level, transferrin saturation, ferritin level, control blood pressure. Now, before you start these agents, you want to normalize this patient's blood pressure. You want to control their blood pressure. Because these agents can also increase blood pressure. The agents can also increase blood pressure. This was one of the initial effects that was seen when these drugs were initially approved. They can also accelerate the blood pressure. So the blood pressure needs to be controlled before you place the patient on this agent. So you also need to do baseline iron studies. Okay. In terms of effectiveness, which was what I asked a while ago, you look at reticulocytes. So usually it's going to be between 7 days and 10 days. You start to see increase in reticulocytes. Hemoglobin, which is what we monitor, is going to take anywhere from 2 to 6 weeks. So now the hemoglobin level is not going to change in enough for you to know that the patient is responding if you're gonna wait 2 to 6 weeks. So within 10 days, you can check the reticulocytes. It should be increasing. Now, within that 10 days, the reticulocyte is not increasing, then you need to reassess what you're doing. So the earliest parameter we can use to determine response is to look at the reticulocyte count. It should be increasing within the first 10 days. If you're not seeing any increase, then you need to reassess what you've done. And one of the things that you need to reassess will be iron levels. Because if the iron is still deficient, you cannot make the red blood cells. Iron deficiency is usually the most common cause of failure when you give these medications. So that's why it's very crucial that the iron levels need to be monitored. So not only should the iron levels be normal, when you start using these agents, that will also increase the utilization of iron. When you give this agent for the red blood cells to be made, you're also going to increase the use of iron. Now, what about, we said the hemoglobin is going to take about 2 to 6 weeks, but you want this hemoglobin to be up right away. What are you going to do? You're not going to wait 2 to 6 weeks, but you want it up right away. The information is on the slide. You give packed red blood cell. Where is it? Do I have it here? Yeah, you give packed red blood cells.
What is it?
Packed red blood cells, RBCs. So you infuse the patient with red blood cells because you cannot wait. You want to raise the hemoglobin level right away. So usually give 1 to 2 units depending on how much level of the hemoglobin. For example, if the patient's hemoglobin is 9 and your target is to raise it to 11, you're going to give 2 units of packed red blood cells. One unit will raise the hemoglobin by 1. 1 unit of packed red blood cell will raise the hemoglobin by 1. So if your target is to raise the hemoglobin by 2, you need to give 2 units. So, however, by using erythropoiesis stimulating agents, then you don't need to use much of packed red blood cell and the associated risk of infusing packed red blood cells. So if the patient is on erythropoietin stimulating agents, their need for blood transfusion will be reduced. But again, if you want to raise your hemoglobin level rapidly, you're not going to wait for the erythropoietin stimulating agents. You're going to give them packed red blood cells. And the amount of packed red blood cells you give depends on your target of hemoglobin. How high do you want to raise the hemoglobin? By 2 units, by 1 unit? For every unit you give of packed red blood cell, your hemoglobin is going to rise by 1 unit. And if you also want to monitor the hematocrit is going to change by 3 units. So the ratio is 3 to 1. 1 unit of packed red blood cell will raise the hemoglobin by 1. It will raise the hematocrit by 3. Now, you give them back red blood cell, because it's a foreign substance, some patient may react to it. So there's a protocol depending on the institution where you may have drug like Benadryl available, glucocorticoid available, just in case the patient has reaction. If they have reaction, you can give them diphenhydramine, hydrocortisone, and they may also have a change in increase in blood in temperature. Acetaminophen will come in there. Because you're also giving volume. You may also see an order for furosemide. You may see an order for injectable IV furosemide because you're giving volume. Typically, if you're giving 2 units, you will see the order for furosemide to be given between the units. The order for this furosemide will be to be given between the units. So basically, you don't want you don't want the patient to be volume overloaded. Okay, so this is a black box warning for the erythropoietin stimulating agents. We don't want you to shoot for a high level of hemoglobin, we said 11. Higher levels increase the risk of death, MI, stroke, and patient can have CHF that require hospitalization. So this is a black box warning for all the erythropoietin stimulating agents. That's why you want your target to be around 11. Okay, so these are some of the pertinent labs. Okay, I think this is the last slide that I have. Any questions?